Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice and typical example of cervical adenocarcinoma, the usual type HPV-associated. So this is a case of a 41-year-old female patient who was discovered to have cervical mass. And this is a section from the biopsy on which the diagnosis was based. Now, as you can see, we have here glandular proliferation as well as exuberant papillary proliferation, exophytic part of the tumor, and this is the endophytic invasive part of the tumor. Now, at low power magnification, the first thing that might come to mind is whether this is an endometrioid carcinoma or not. And this is a slight, small tip that you're probably dealing with the usual type cervical adenocarcinoma HPV associated. Please always be careful or mind the site of the tumor as well as the age of the patient. So this is the first hint to the diagnosis. Now, on medium power magnification, as you can see, we have this malignant glandular proliferation with a cigar-shaped nuclei, stratification, loss of polarity, or features of malignancy. But in addition, there are two features that can help to support the diagnosis that this is HPV associated. And these are basal apoptosis and floating or apical mitosis. Now, in order to fulfill these criteria, first of all, these have to be detected in an adenocarcinoma on low or intermediate power magnification. So the both of these features have to be seen easily, mostly at intermediate power magnification, like ×10 or maximum ×20 lens. And then you start to see those explosive apoptotic bodies, mostly confined to the basal part of the epithelium near the basement membrane. In addition, you see mitotic activity, and the mitosis is usually seen towards the luminal part. This is why it's sometimes referred to as floating mitosis. This is another focus of the tumor, where we can beautifully see the basal apoptosis here. As you go along the basal layer of the epithelium, you see many of those apoptotic keratinocytes, apoptotic bodies at the basal part of the glandular epithelium versus the luminal place for the mitotic figures. Both of these features, when seen together in a cervical adenocarcinoma, are strong supportive features for HPV-associated cervical adenocarcinoma. If you don't have the P16 immunohistochemistry, you can rely on both of these to separate cervical adenocarcinoma HPV-associated from the HPV independent. Now, in our case, we have the P16 surrogate marker immunohistochemistry, and as you can see, this is what we call a block positivity, where we see almost all the cells and the nuclei, the cytoplasm and the nuclei of the tumor cells are strongly positive, adjacent to each other. This is the pattern that we should see in order to call the P16 positive in a block positivity that would act as a surrogate marker for high risk HPV infection. So the final diagnosis in this case is endocervical adenocarcinoma, usual type HPV associated. Remember that you have always to pay attention to the age of the patient as well as the location of the tumor. You have always to pay attention to small subtle clues that can help you to render the diagnosis. In this case, the association with HPV, with high-risk HPV. These are the basal apoptotic figures and the floating or the apical mitoses detected on low to intermediate power magnification. Why we need to separate the HPV associated from the HPV independent cervical adenocarcinoma? Because of the difference in the prognosis and the outcome. The HPV independent cervical adenocarcinomas are associated with more aggressive behavior compared to the HPV associated. Remember that we call the tumors that are linked to HPV, high risk HPV infection, HPV associated. We don't call them HPV dependent. The word that is used by, the phrase that is used by the WHO is HPV associated, versus the tumors that are not linked to high-risk HPV are called HPV independent cervical adenocarcinoma. I hope you find this tip useful in your daily practice. Thank you.